Today, I would like to welcome Dr. Harvey Abrams, who is a PhD audiologist. Dr. Abrams has held academic, clinical, research, and administrative positions with the VA, Veterans Hospital, the Department of Defense, in academia and private industry, in an amazing career spanning more than 45 years. Dr. Abrams, welcome. Dr. Abrams is currently serving as the head of research audiology at Lively Hearing, which is a tele-audiology focused company. Dr. Abrams, what is going on in your world?
Well, first of all, thank you for the invitation, Dr. Thompson. Please call me Harvey. Okay. So in my world, things are quite exciting. Of course, you probably have heard and your audience have heard about the over-the-counter hearing aids, sort of an exciting thing in the profession. After a long career working in sort of large organizations like the VA and Department of Defense and teaching, my work with Lively is kind of an interesting end of the career. I hope it lasts a bit longer than a few years, but it's very different than the things I've done before. So we can talk about that in detail if you'd like. But that's what's keeping me busy. And I also continue to teach. I'm teaching at 3 different universities now. I'm teaching Doctor of Audiology students, which is always a joy for me to kind of pass on information and my experience to another generation.
Yeah, excellent. Let's talk about over-the-counter hearing aids. You've studied them. Legislation has come out. The FDA in the United States has a lot of time to build this policy or these guidelines for over-the-counter hearing aids. Now we're in this time period of public comment. So what are your thoughts, initial thoughts about the recommendations?
Yeah, very interesting because kind of my thinking has evolved here. When the issue was first being discussed, I actually was a consultant for the Hearing Industries Association. I was head of research at the audiology department at Starkey. And our position at that time was, as it continues to remain, that the best outcomes involve the participation of an audiologist. We're a little concerned that OTCs were going to be approved for individuals with mild to moderate hearing loss. That's a very wide range, by the way. And mild hearing loss, of course, we absolutely can understand that. I think that makes sense. But when you get to the more severe end of moderate, you're talking about individuals with fairly significant hearing loss. Hearing loss, of course, is more than just not being able to hear things, right? It's not just an audibility issue, it's an understanding issue. There are changes that occur in the auditory system as a function of aging and noise exposure to the most common sources and reasons for hearing loss. And it's damage to the delicate structures in the inner ear, the nerves. And once those are damaged, they don't grow back. And the consequence include a difficulty understanding of speech, even though you can hear it. So simply by amplifying speech, which over-the-counters may do quite well, the sophisticated signal processing that needs to happen, that is best adjusted and fine-tuned by a professional audiologist, is not part of the over-the-counter model. Now, you mentioned about how long it's taken for the over-the-counter rules to be published. I think the law was passed and signed in 2017, isn't that right? And so we've had a good 4 years. And during that time, I mean, technology, as is always the case in our field, has just exploded. So even over-the-counter hearing aids are going to have much of the technology that prescriptive hearing aids currently have. A lot of the advanced features like noise reduction algorithms and feedback management and directional microphones and so forth. And that's all great. And those will be wonderful features in these over-the-counter hearing aids. However, we're still talking about just technology, just the technical aspects of improving hearing. And there's a lot more, because even with the best technology, for many individuals with more severe hearing loss, the consequences associated with that hearing loss are not going to be resolved simply through technology in and of itself.
The professional services and the technology coming together leads to the best outcomes. As a researcher, what have you found over the years that seems to always point back to what the audiologist is providing that some of these over-the-counter hearing aid companies should really pay attention to?
Well, for one, we try to match that technology to the patient's needs. Now, if you don't know what the patient's needs are, you can't develop a treatment plan that includes the appropriate selection of style and of features. Knowing what your goals are, knowing that in fact you want to be able to communicate better at your bridge club, for instance, tells us a lot about what kind of features need to be included in the hearing aids. If all you need, however, is to have the TV amplified so that you're not driving up your spouse out of the room when you're watching TV, well, that tells us that perhaps you don't need a sophisticated technology that others might require. So being able to identify those needs by questioning the patient as the audiologist serving as a facilitator to identify and articulate those needs. Without that, then the match between the technology and the patient's needs are not always going to be well met. In addition, the counseling that goes into reasonable expectations are very important. Hearing aids are not like eyeglasses. With eyeglasses, you know pretty much right away whether or not this is the right prescription for you. Things not automatically, but immediately either are clear or they're not clear. If they're not clear, you need an adjustment. If they are clear, you're good to go. Hearing aids, even when they're fit precisely, still require time in order for the individual to adjust to kind of this new sound. The brain needs to relearn what these amplified sounds are. When we're first fit with hearing aids, every sound is different. We need to learn to ignore those sounds that don't necessarily have any importance for us and attend to those that do. And that comes over time. That kind of counseling is important in terms of expectations of hearing aid benefit. I would add that depending on the results of the test, it may be that the goals that the patient wants to achieve are just not achievable with just the hearing aid itself. It may be that their speech and noise understanding is so poor that we need to have a discussion about other types of assistive technology that might involve, for instance, remote microphone technology, or some kinds of connections to peripheral devices like your TV and your telephone, which will enable better communication and understanding with those devices. Again, those are situations that are not going to be addressed by simply purchasing a device at your local drugstore.
That retraining period you spoke of, that after a new hearing aid fitting, the brain has to reorganize and restructure. Well, for those of us in the tinnitus community, this is no new concept. Tinnitus retraining, anyone who has gone to learn about how can my tinnitus reduce over time, it's also using the positive change element in the brain. From your research of auditory training, tinnitus retraining, the hearing adaptation phase, what have you found? What interests you? What fascinates you in that space?
Yeah, so that's what you're describing, of course, is known as neuroplasticity. It's the fact that in the absence of stimulation or in the presence of new stimulation, the brain actually not only restructures itself, it actually grows new connections, new neurons, because this new information is creating a richer source of information. And that's a good thing for most of us. Tinnitus also, unfortunately, is a stimulus. It may be a stimulus that not necessarily occurring from the outside, but something that happens due to some pathology. And that also results in reorganization. From a hearing aid perspective, again, as we're stimulating the auditory system with new information that perhaps you had when your hearing was normal, but now it's restored, new pathways are going to grow. And it takes a while for the individual to understand and capitalize on that new information. Again, so Ben, I often use this analogy. I have a patient sitting in front of me. I said, "Can you feel your arm on the chair?" He said, "Well, yes, you can." I said, "Yeah, you can, because I pointed it out to you a moment ago. Probably you didn't even notice your arm was resting on a chair." And what happens when we fit individuals with hearing aid is that because they're hearing these sounds, for the first time, or they're hearing all sounds differently, they're paying attention to it. That's what we do. It's a good thing. It's a part of our survival instinct, right? To attend to new and unusual, novel stimuli. However, over time, we learn to ignore what's common. We learn to ignore what's unimportant. We learn to ignore what's not danger. And we learn then to focus on what is important, the speech information, for instance. And that just takes time. It doesn't take a lot of time, by the way. We usually find that within 30 days, individuals have fairly well adapted to hearing aids, assuming, of course, they're wearing them most of the day. Part of the problem among individuals who only wear them a few hours a day, they really never adapt to it. And so they'll often complain about same thing on day 25 and 26 as they were complaining about on day 2, right? That all these sounds are annoying. I hear the refrigerator. I hear myself walking. Yeah, but when you start wearing your hearing aids on a regular basis, again, those will just become part of the normal acoustic landscape, and you won't pay attention to them anymore.
Yeah, good point.
Now,
So about
yeah,
1 month. 1 month is a good benchmark of
yeah,
use them full time as at a comfortable level, slowly getting to that prescribed or recommended level. And
right.
a month is reasonable to check in with your provider, with your audiologist, and ask, okay, it's been a month. This is where I'm at. Now what? That's where the professional expertise comes in hand.
Yeah.
Do you have any other points on this?
Well, I was talking about the fact that even the best hearing aids may not necessarily resolve all of the patient's complaints, particularly if they have a lot of difficulty with speech understanding and noise. Well, but that's not the end. Technology is not all there is. And audiologists may engage the patient in post-fitting services and programs. And we call this audiologic rehabilitation and auditory rehabilitation. And this can consist of auditory training, which is kind of like brain training for the ears. There are several of these products on the market. Lace is an example of it. There are some products that are not necessarily designed specifically for hearing, but are called brain fitness games. And these are like Brain HQ is one, Lumosity is another, and perhaps the audience may have heard some of these. Lumosity is often advertised. And these are designed to improve your ability in terms of speed of processing, auditory attention, and focusing on the target and ignoring the information that's not important. These are all we call central processing features that tend to get compromised as we get older. Oh, the other is working memory, by the way, which tends to get compromised. And so working memory is a real problem as we get older, particularly in difficult listening situations, because we're trying to attend what's being said. We kind of capture the beginning. And then as we're struggling to hear the rest, we don't remember what the first few words were. And we lose context and we lose necessarily the understanding of what's being said. So some of these brain training games work on working memory as well, which is an important component of processing information, whether it's auditory or visual or any other.
It's good to bring that in. Now, Harvey, let's talk about the internet. Let's talk about telehealth, tele-audiology, whatever we want to call it. Seems like your newest research has taken a strong step into this space. Am I right?
Well, yes. So even in the space we were just talking about, such as auditory training, it really doesn't necessarily have to be done in the clinic. One of the nice aspects of these are that they can be done on your phone, it can be done on your PC, and they keep track of your progress. We call this gamification. And if any of you wear Fitbits, for instance, this is a type of gamification. These systems have gamified things like health and wellness, which in the past have really not been games. The benefit of gamifying something is that it taps into kind of the human need for results, for reward, sometimes for competition. And so you might share your results with other people in your group, and there you get some recognition for it. That's kind of that idea of gamification. And we've got many of these that are available, again, on the internet or on your phone. In addition to the ones I've mentioned, some hearing aid manufacturers have created these gamified auditory training programs. Starkey, for instance, has what's called Hear Coach. And it provides these words in a background of noise. And if you get the words correct, the noise gets louder. If you're having trouble with identifying the words, then the noise gets softer. And over time, you gauge your progress. And research has shown that these games really do work in terms of improving your ability to understand speech in noise and also your ability to understand more rapid speech. But like any games, any kind of training program, it really requires compliance and requires that you engage on a regular basis. I often compare these to learning a foreign language. There are also wonderful applications out there for learning a foreign language. However, unless you commit to engaging in these programs on a daily basis for at least like 15, 30 minutes, they're not likely to result in significant improvement in your ability to learn a language, or in case of auditory training, in your ability to improve your understanding in noise, for instance.
Thank you for that.
Yeah.
With lively hearing, what have you learned about the behaviors of adults aged 55 to 80, and then how they're responding to telehealth and remote hearing aid fittings and so forth?
Sure. So just to review the Lively model, we are a total telehealth model. There are a number of telehealth applications or teleaudiology applications, and they have various combinations of in-clinic versus remote services. So in some cases, a patient will go to a clinic, they'll get the hearing tested there, they'll come back to get fitted with the hearing aid, and then future adjustments can be done remotely. In other cases, they still may get their test in the clinic, but then the hearing aid can be pre-programmed and mailed to the patient, and follow-up services can be done remotely. Lively, I believe, is the only model in which everything is done remotely. So we have an online hearing test that the individual takes. It's sort of like, it's like the test you take in a clinic. They're kind of beeping sounds, and we measure the lowest level at which you can hear those tones at different pitches. That generates a report that indicates the amount of difficulty an individual has at different frequency ranges. On the basis of that, we pre-program the hearing aid, send it out to the patient, and on the day the hearing aid is received, they usually get a call from somebody in our technical support staff that at least helps them unpack what's in the box, get it on their ears. And soon after that, we'll make sure they have downloaded the appropriate applications. One is the application that will help them to self-adjust their hearing aid. Also, the application allows us to adjust the hearing aid remotely, as well as Zoom, the sort of application we're dealing with now, because within about 5 days or so of receiving the hearing aids, they will have a consultation with one of our audiologists. At that point, the audiologist will begin to discuss what I had mentioned before about establishing treatment goals, and making any further adjustments to the hearing aid if needed at that point, making sure the patient understands the proper operation and maintenance of the hearing aids, understand expectations based on the evaluation, and establishing those treatment goals. Then we will follow up if we don't hear back from the patient within 2 weeks, and again in 4 weeks, and determine the extent to which the patient's goals have been met, have been achieved, or we can make any necessary adjustments at that time as well.
So what has your research been focused on mainly?
Well, we're interested in patient outcomes, right? Because this is kind of a new model, and we want to know whether or not our patients are achieving those goals using this model. And so we use what's called a COSI. COSI stands for Client-Oriented Scale of Improvement. There are many scales out there that we can use, many questionnaires out there that we can use that measure a pre-fitting performance and a post-fitting performance, and there may be a score, and then a different score indicates the amount of benefit. I personally prefer the COSI because what the COSI does, it identifies those situations that are most important for the patient to resolve. These scales typically have preset questions. Many of them are the ones that typically cause problems for people with hearing loss, like TV, hearing a whisper, communicating in noisy environments. But we don't know on the basis of those questions how important those situations are for that patient to resolve. The cozy, on the other hand, is a blank piece of paper, essentially. And what we want to know is from the patient, why did you come to us? What is it that's causing you your greatest difficulty that you feel you need help? And through a questioning and answer and facilitating this conversation, we can get to maybe the 3 or 4 major issues that are causing the patient most problem. Could be they're having trouble hearing their communication partner in their favorite restaurant that they go to every Sunday after religious services, right? So that's causing them a lot of frustration. And we'll write that down. And then it's, well, I have to turn the TV up so loud. My wife tells me to watch it in another room, right? So that's a situation that's causing a lot of problems. I'm having trouble understanding my grandchildren, when the family comes over for Sunday dinner, right? Or I'm having trouble hearing on the phone. Whatever those are, there can be many. Trouble hearing the pastor at religious services. Well, those are the ones that they've identified, the patient has identified as those problems that are causing the most difficulty. We write those down, and as I mentioned earlier, by knowing what they are, they also help to drive some technology and feature and style decisions. Well, at Lively, honestly, it doesn't drive a style decision because we only have one style, but it does drive perhaps the feature decisions in terms of how we set the programming and how we program the hearing aids. Now, when they come back for follow-up, they of course don't come back. When we meet with them on a remote consultation, we then determine the extent to which each of those situations have been improved. And with the COSI, they will tell us, well, whether the situation is no better, a little better, or a lot better. And that's what we're looking at primarily in terms of our Lively model. And so we've collected data on many, many hundreds of our clients. And 95% of all of our clients report that situations are better or a lot better than they were before the fitting.
Good validation measures there. That's what we
Right.
want to see. That's why
Yes.
we know our job is valuable. And quite honestly, showing that telehealth is here to stay, not for the
sure.
future, but for the now. I wanted to give you an opportunity to give some closing remarks here for the tinnitus community. You've worked with many veterans, and I wanted to just ask you point blank, can tinnitus get better? Is it possible to improve life with tinnitus? Is it possible to reduce tinnitus to some degree in certain cases? We need more positivity and optimism and hope in this tinnitus community. From what I've seen, I'm more vocal about sharing, hey, if you're in the majority, you're going to get better. It's just a matter of time and keeping everything on the right track. Do you have any last words for the tinnitus community, Harvey?
Oh, for sure. And you're right. After some 35 to 40 years in the VA, I've managed thousands of individuals with tinnitus. And what I've learned, I'm sure, is what you've articulated too, is that there is a range of difficulty with tinnitus, of how much it disturbs an individual, from the mildest, which is, if you ask them, yeah, I have tinnitus. Does it bother you? Well, not particularly. If I think about it, I know it's there. To those who just can't stop thinking about it, where it becomes a true quality of life issue, and in some cases, it's so disturbing that they may require some psychological care for how much it disturbs them. So this is really wide range. And because it's such a wide range, there's just a huge toolbox at our disposal. At the very least, and I know you've probably talked about the work of Dr. Henry, we call this progressive tinnitus management, because a different approach will work depending on the level of disturbance. So at its very mildest disturbance, sometimes just knowing that this is not a symptom of a serious illness or a disease or a disorder or a growth or something like that is enough. That's all our patients need, some reassurance that this is not a symptom of something dangerous, and end of story at that point. In most cases, as you know, tinnitus is a byproduct of this kind of hearing nerve disease that I was telling you about before. And unfortunately, when our hair cells are damaged, they create this sound that often corresponds to the frequency or pitch where the hair cells are most damaged. So we usually find high frequency tinnitus if we match that tinnitus. Very often, because they have hearing loss, we're going to fit them with hearing aids. And very often, it's the hearing aids themselves help to cover up the tinnitus, at least to a certain extent. Enough so that the tinnitus no longer becomes as disturbing as it was before. So that's kind of the next level, right? We're just providing something we would have provided you even if you didn't have tinnitus. But a nice positive byproduct of that is that it reduces the level of tinnitus, the disturbance level, the noticeable level of tinnitus. So Ben, you might be interested in this. It's one of my first, I think my first research project I did at the VA was after wide dynamic range compression hearing aids hit the market. And one of the wide dynamic range compression hearing aids were wonderful, great technology, because it solved that problem of amplifying the soft sounds while reducing the gain as the input got louder. So we kept that range between what's just barely audible and what's uncomfortably loud within a nice, comfortable range. Well, it turns out when you amplify those softest sounds the most, all of a sudden now you're hearing some circuit noise. Now we've fixed that problem through a technology called expansion technology, but in the beginning, hearing aids that employed wide dynamic range compression were noisy hearing aids. Well, son of a gun, if that didn't also help to reduce the tinnitus. And so my first study was to explore the effect of wide dynamic range compression on tinnitus complaints. And it turns out, I think it was 75% of all of the patients I fit with wide dynamic range compression hearing aids noticed at least some reduction to their tinnitus. Isn't that interesting? All right.
Did you find that was significantly better than the other hearing aids at the time, the status quo
the
hearing aids?
linear hearing, of course, because with linear hearing aids, gain was the same no matter what the input level is. And so you didn't have the microphone noise. You didn't have as much circuit noise that was noticeable to the individual because they usually had hearing loss where, that circuit noise was. And so we noticed that it was different between those who had linear hearing aids and wide dynamic range compression hearing
Excellent.
aids.
Well, that's an amazing research study, and it relates back to what my YouTube community has been so focused on, which is managing tinnitus. It is manageable through your years of experience helping military veterans, even those with significant cochlear hearing loss or cochlear tinnitus. It can still be manageable, and that's our message. Other types of tinnitus can also be managed. It's a complex medical condition, so having professional team involved is the right approach. Progressive tinnitus management, tinnitus retraining therapy, cognitive behavioral therapy, whatever works, that's what we want the patient to have.
Indeed, yeah.
Harvey, last words for you. Do you have any final words here? And again, thank you for coming onto my podcast to share your knowledge and wisdom with us.
My final words are that we should continue to keep track of what's happening in this field. I've been doing this for almost 50 years, and it never ceases to give me pleasure and joy. The technology continues to advance, our knowledge continues to advance, our opportunities of helping those with hearing loss and tinnitus continues to improve. It's just a joy to be working in this field. Now we're getting into approaches like telehealth and teleaudiology, which makes what we do more accessible and more affordable to individuals who need hearing health care.
Completely agree. Thank you so much, Dr. Harvey Abrams, for joining us. Everyone who's listening, you can check out the other podcast episodes for conversations and interviews with other professionals to help you with hearing conditions. Thank you and take care.
Thank you.